Hello and welcome to the webcast on Neuroleptic Malignant Syndrome, or NMS, Recognition and Management. I'm Stanley Caroff from the VA Medical Center and the University of Pennsylvania Perelman School of Medicine in Philadelphia. This program was supported by an educational grant from OSMOTICA Pharmaceuticals, and my financial disclosures are listed on the screen. So we're going to review some clinical aspects of NMS, recognizing the clinical signs and diagnostic criteria, talking about the incidence and risk factors, discussing the differential diagnosis, and covering some strategies for treatment of the disorder. Now, the program is also sponsored by the Neuroleptic Malignant Syndrome Information Service, or NMSIS, the mission of which is to promote education and research on NMS and a number of related syndromes. You're welcome to contact us at the website and phone number listed on the screen if you have any questions about cases related to these syndromes. Now, in terms of history, NMS was first described by Delay et al. In France in 1960 in this paper during early studies of haloperidol. And the authors state that, as with other neuroleptics or antipsychotics, it's possible to observe cases of a severe side effect that consists of sweating, dehydration, hypothermia, altered consciousness, which are the principal signs of what they called syndrome Milan or malignant syndrome. They observed 5 cases out of several hundred patients treated with haloperidol. The treatment they recognized consisted of immediate stopping of haloperidol treatment and rehydration. They never had any fatal cases, but they understood that that was possible. And they noted that this side effect was not due to overdose, but could be seen with moderate doses at the beginning of treatment. So even this early on, investigators knew many of the essential features of NMS. But unfortunately, recognition of NMS as a severe antipsychotic and new side effect was not observed and widely known for many years after this, outside of France and Japan, with unfortunate tragic consequences for many patients. So let's talk a little bit about what NMS looks like, the clinical signs. Certainly there has to be association with treatment using dopamine receptor blocking agents. It takes the form of a hypermetabolic or hyperthermic crisis in its most fully developed form, with high temperature, sweating, trouble breathing. Parkinsonian signs such as rigidity, tremor, dysarthria, dysphagia, and sialorrhea are prominent. Altered consciousness is seen, especially catatonic stupor or delirium. Marked autonomic changes in heart rate and blood pressure can be seen. There are a number of laboratory findings, such as CPK elevation, that are associated commonly with NMS, but they're nonspecific and important to do to rule out other disorders, but are consistent with the diagnosis. And finally, it's important to point out that NMS is a diagnosis of exclusion, and it's not due to other drug-related, systemic, or neuropsychiatric conditions. So these signs were standardized in a study using an expert panel to reach consensus, and each of the symptoms or signs were assigned a priority score. For example, exposure to a dopamine antagonist received a score of 20, hypothermia received a score of 18, and so forth, to derive a severity score to assess the likelihood of the diagnosis of NMS. And in comparison with diagnostic criteria in DSM or consulting experts' clinical diagnoses, a cutoff score of about 70 to 74 indicated a high likelihood that the patient had NMS. So this is a scale or consensus criteria that can be used to assess the possibility of NMS being the correct diagnosis. Now, how common is NMS? Here's a list of many studies looking at the incidence of NMS among patients treated with antipsychotics. The percentages range considerably depending upon the sensitivity of the criteria and the investigators used in these studies, but generally speaking, the larger the sample of patients, the lower the incidence rate that was recorded, and probably more accurately so in a larger sample. And if you pool all of these studies, the overall incidence rate was about 0.2%. It was about 1 in 500 treated patients. However, more recent studies with large databases in studies from Russia and Germany showed that the incidence rate was more likely to be about 0.02%, or about 1 in 5,000 patients treated with antipsychotics. And interestingly, the study by Stubner and al. Broke it down by antipsychotics, showing that the less potent drugs like clozaril were probably 10 times less likely to cause NMS compared to higher potency drugs like haloperidol and risperidone. Another example of the frequency of NMS is displayed here in a graph of figures taken from the AHRQ website. These are the number of patients with NMS who were diagnosed in hospitals in the United States during the years on the x-axis. And you can see about 2,000 to 2,500 patients are diagnosed annually with NMS in hospitals in the United States. So it's not a common disorder, but it certainly is not rare and is likely to be encountered in most medical centers. So to summarize, NMS occurs in about 1 in 5,000 patients treated with antipsychotics. The second generation newer antipsychotics do cause NMS, but probably at a reduced rate. And finally, as an aside, it's not really clear whether milder forms of NMS occur in association with the newer drugs compared to the older drugs. Well, let's talk about risk factors for NMS. Is it possible to develop a profile of which patient might be likely to develop NMS? And so there are a number of studies that have looked at this. Sex and age don't appear to be terribly helpful. The metabolic state, for example, dehydration or low serum iron have been implicated. Agitation. Certain diagnoses may be more likely to result in NMS when treated with antipsychotics, for example, pre-existing catatonia or encephalitis. A number of authors have looked at possible genetic signs or polymorphisms in the dopamine 2 receptor and rhianodine receptor in skeletal muscle, but these are small case series and really have not been replicated. And finally, in terms of patients' conditions, NMS is not restricted to hot weather or heat stroke, and it can occur in cold weather and cold climates. In terms of possible treatment-related risk factors, among published studies, about 17% had a previous episode of NMS. It's important to conduct a drug history. All classes of antipsychotics have been implicated, haloperidol, though, most often accounting for about 50% of reported cases. And generally, higher potency, higher doses of drugs more likely to cause NMS, especially when given parenterally at a rapid rate of increase. There's not clear evidence that long-acting injectables are more likely to cause NMS. NMS is really a disorder that occurs during the early phases of treatment. It's not clear whether adjunctive drugs like benzodiazepines or anticholinergics could prevent or increase the risk of NMS. Finally, dopamine-depleting drugs like the new VMAT2 inhibitors or withdrawal of dopamine agonists in Parkinson's disease patients can also produce an NMS-like picture. I think the take-home message is that all drugs that block or reduce dopamine have the potential to cause NMS. Now, among cases of NMS called into the NMSIS hotline in early years, first-generation drugs are more likely to be implicated, although more recently the second-generation drugs are also implicated. But there are other drugs that are used outside of psychiatry in medical settings that are dopamine receptor blockers and may also be implicated in causing NMS. And so let's look at that in a little bit more detail. Here's an advertisement from a local newspaper from a law firm indicating that patients who take metoclopramide, which is used for gastrointestinal symptoms, can act as a dopamine receptor blocker and can cause tardive dyskinesia, and also NMS, which is actually described here fairly accurately. So you have to be aware that some of these drugs with little-known dopamine receptor blocking properties can cause NMS as well. For example, in a perioperative setting, we conducted a review of reported cases of NMS, and the one drug most likely implicated, again, was haloperidol, which accounted for 50% of the cases and is often used for post-op delirium and agitation. But again, there are a number of other drugs, including metoclopramide, that are used in this setting and can also be implicated in causing NMS. Now, again, VMAT2 inhibitors, which deplete dopamine, have also been associated with NMS. So we looked at this in historical literature and can only find about 13 cases of NMS implicating VMAT2 inhibitors, mostly tetrabenazine, which has been around for many, many years. So they're actually very rare cases of NMS. Most of these cases were complicated and confounded by concomitant use of antipsychotics in patients with degenerative disorders like Huntington's disease. But a few of them, the VMAT2 inhibitors, did seem to be implicated in causing NMS. So this is exceedingly rare, but it's also often confounded by other factors. But will have to be considered going forward when VMAT2 inhibitors are used concurrently with dopamine receptor blockers, which is certainly a reasonable and approved use of these medications. But once again, one has to have an increased index of suspicion, awareness of potentially rare incidence cases of NMS. So regarding risk factors, there are a few controlled studies. Some variables might be useful, like pre-existing catatonia. You try to avoid excessive rapid increases of dosages where possible. But it's important to note statistically that risk could be exaggerated when you're looking at a rare event like NMS and comparing it with risk factors that are very common. For example, patients with agitation are very common and appropriately treated with antipsychotics. So it may be statistically associated with NMS, but it's not a particularly helpful indicator for clinicians in practice. And so no risk factors have been reliably proven to outweigh the benefits of antipsychotics in a given patient. It's important also to be aware of early signs of NMS, to pick it up early so you can stop the antipsychotic. And here are a list of some possible early signs of NMS: delirium, catatonia, autonomic changes, sweating, refractory extrapyramidal problems, and elevated CPK. Now, Bellamore et al. Looked at published cases to see if there were presenting early warning signs of incipient NMS. In the majority of cases, the first signs were neurologic in terms of change in mental status or rigidity, and only later on did this generalize to systemic disorders with fever and autonomic signs. So early extrapyramidal problems, mental status changes during antipsychotic treatment certainly are not uncommon, but should be monitored carefully for signs of progression to NMS. It's important to recognize these early signs. Usually, again, puzzling, refractory, neurologic, or autonomic signs should raise suspicion. However, early signs are not specific and do not necessarily progress to or precede NMS in all cases. What about the course of NMS? So here's a graph of reported published cases of NMS. And you can see that NMS is really a disorder that comes on in the early stages of treatment. About 2/3 of NMS cases develop within 1 to 2 weeks of the initiation of antipsychotics. It's uncommon for NMS to occur after 30 days of treatment unless the doses increase or a second agent is added. Conversely, once oral antipsychotics are stopped, NMS is self-limited in most cases. The average recovery time is about 7 to 10 days. About 2/3 of patients recover within 1 to 2 weeks after antipsychotics are discontinued. However, not everybody recovers that way. We do know that there are some residual catatonic Parkinsonian states that emerge and may last weeks to months after NMS resolves, the metabolic signs of NMS resolve. In these cases may be responsive to ECT or dopamine agonists. It may be the case that NMS may be increased in duration with long-acting injectable drugs, but patients with severe NMS are, of course, at risk for serious, potentially fatal complications that are listed here, including cardiorespiratory arrest, pulmonary emboli, renal failure, or DIC. Autopsies are usually non-specific. Now, regarding the mortality rate of NMS, there are a number of series of cases of NMS that have been reported in the literature. The fatality rate early on in early cases was quite high, up to 1/3 of patients. But in most centers, the mortality rate declined among these series of cases. And if you pool all this data together, about 10% of cases resulted in death among small series of NMS patients. Patients who died were more likely to be older and have higher temperatures. Intuitively, that makes sense. And in at least this unpublished review of published cases, long-acting injectables were associated with fatalities, the development of coma, and prior organic brain syndromes as well. Now, it's interesting to look at the mortality rate in Japan, where NMS was taken seriously from the very earliest days. And you could see in the dashed line that as the number of cases were recognized and treated quickly, discontinuation of the antipsychotic, the mortality rate declined proportionately. So it's very important to recognize NMS, be familiar with it, even though it's rare, and that could lead to improved outcomes, as I think it has over the years. So let's move on to treatment of NMS once it occurs. General measures are the most important and the mainstay of treatment. As we said, early recognition, discontinuing antipsychotic drugs, supportive medical and nursing measures such as physical cooling, fluid balance, watching for complications. Now, in terms of specific pharmacotherapy and ECT, this has been discussed at length in terms of whether there are specific agents that can be used to treat NMS. Now, NMS is difficult to study. There are really no randomized controlled trials. It is very rare. It is heterogeneous in presentation and outcome, and it's often self-limited when recognized and the antipsychotic triggering drugs are discontinued. Nevertheless, a number of agents have been proposed based on theoretical reasons that might be helpful in NMS, and there are case reports supporting these various agents. So, for example, lorazepam, which is the initial treatment for catatonia, has been used. Amantadine and bromocriptine, which have anti-Parkinsonian effects, have been used. Dantrolene, which is a primary skeletal muscle relaxant, is very effective at reducing muscle rigidity and heat generation, and has been useful in serious advanced cases. And finally, ECT, which is a treatment of choice for people with catatonia who don't respond to benzodiazepine, and that's been used as well. And how best to use these? Well, it may be best to use these empirically based on clinical judgment and the stage of symptoms, the severity, and the duration of the symptoms. So, for example, in the early stages of antipsychotic-induced Parkinsonism or catatonia, that may prompt thoughts about modifying antipsychotic drug use. Lorazepam is very good for catatonia. Anticholinergics or amantadine are very good for Parkinsonism, although anticholinergics, by the way, are not worth using or even contraindicated in patients with fever or high temperatures because it inhibits sweating and can worsen that condition. Now, if the patient moves on to a more clear-cut NMS presentation, not only with catatonia and Parkinsonism, but elevated temperature and heart rate, that should prompt consideration of discontinuing the antipsychotics and monitoring the patient carefully. At this stage, at a more moderate stage of NMS, lorazepam, bromocriptine, or amantadine can be used, or ECT if these drugs fail to be effective. And finally, in the most severe hypermetabolic form of NMS with severe rigidity, mental status changes, temperatures above 104 degrees Fahrenheit or 40 degrees centigrade, you must discontinue antipsychotics, provide aggressive supportive medical and nursing care. And here's where dantrolene might be helpful because of its skeletal muscle relaxing effects to reduce temperature. Bromocriptine, amantadine can be useful as well. And finally, ECT, which is effective for catatonia and malignant catatonia. So, as illustration, here are some examples of actual cases. This slide shows a patient who had a heart transplant and was on multiple medications, including the dopamine blockers, metoclopramide, haloperidol, and droperidol. Developed a temperature up to 108 degrees Fahrenheit, 42 degrees centigrade. Dantrolene was given, resulting in rapid decrease in temperature, which began to creep up again, but responded a second time to dantrolene as well. This is a typical and good illustration of the use of dantrolene. Ativan or lorazepam, used in this graph on the left, in a milder case of NMS, resulted in a reduction of temperature, and apomorphine, a dopamine agonist, used on the right, also resulted in some improvement of symptoms. Another treatment problem occurs with patients who recovered from NMS or have a past history of NMS, and whether one can restart antipsychotic treatment. Well, we believe from published cases that there is a higher risk of recurrence, up to 30% in patients who had NMS before. Some steps can be taken in the decision to re-challenge with antipsychotics. Check their prior episode to make sure they really had NMS. Document the indications for antipsychotics versus other treatments like antidepressants or mood stabilizers. Minimize risk factors such as dehydration. Wait at least 2 weeks after recovery from NMS. Give a test dose of a low potency or atypical drug with gradual titration and careful monitoring. And it's probably a good idea to document informed consent when restarting an antipsychotic a patient who had NMS in the past. So to summarize treatment, diagnose early, stop the triggering antipsychotics, provide supportive medical and nursing care, watch for complications. Again, there are no randomized controlled trials or approved treatments of NMS because it's rare, heterogeneous, and may be self-limited after drug discontinuation, which is the primary intervention to perform. But specific treatments could be individualized and prescribed empirically based on the character, duration, severity of signs and symptoms. The risk of recurrence of NMS can be managed such that the majority of patients can be safely treated for psychosis after recovery from NMS. Now let's talk about the differential diagnosis. There are other conditions that simulate NMS. And here's a list of the most common disorders that come up in the differential diagnosis: infections of various types, autoimmune disorders, benign drug-induced catatonia or extrapyramidal symptoms like Parkinsonism, idiopathic malignant catatonia, in other words, malignant catatonia that arises from schizophrenia, mania, agitated delirium of many causes, environmental heat stroke, serotonin syndrome, and withdrawal states such as withdrawal from sedatives, alcohol, or dopamine agonists. And differential can be divided up, as we just stated, into various primary brain disorders, infections, major psychoses that cause malignant catatonia, structural lesions, and seizures or status epilepticus, for example. And there are also systemic disorders, infections, again, of various kinds, metabolic conditions like hyperosmolar diabetic crises, endocrinopathies like thyroid storm or pheochromocytoma, autoimmune diseases, heat stroke, and a number of toxins and prescribed drugs that can also produce hyperthermia and are listed here. About pathogenesis, unfortunately, there are no good animal models of NMS that can be studied, but there's a number of lines of circumstantial evidence that clearly indicate that central acute dopamine reduction or hyperactivity is probably the initial triggering cause of NMS. For example, all the triggering drugs block D2 dopamine receptors. The risk of NMS correlates with D2 receptor blocking potency. Dopamine agonists like bromocriptine may be therapeutic in reversing NMS. And most importantly, NMS-like conditions have been observed following reduction of levodopa or dopamine agonists in patients with Parkinson's disease, and may rarely be associated with dopamine-depleting agents. Some anatomical lesions that impact dopamine pathways can cause an MS-like picture, and there are a number of other studies that suggest this hypothesis may be valid. But there are other hypotheses, such as primary skeletal muscle function, sympathetic system, or other neurotransmitters, and these may be important indicating why NMS doesn't develop in all patients. So to conclude, it's still very important to recognize the signs of NMS, be familiar with NMS. It's rare, 1 in 5,000 patients treated with antipsychotics, but it does occur on a regular basis in most medical centers. The second generation newer drugs may have reduced risk. NMS is self-limited if diagnosed early and the drugs, antipsychotic drugs, are discontinued and appropriate measures are applied. There's really no controlled evidence to approve specific treatments for NMS, but they certainly can be tried empirically, and there is case report data to support their use. It's important to be aware of other disorders in the differential diagnosis, and you're certainly welcome to call the NMSIS consultants for more information at the website indicated on the slide. And finally, by way of illustration, here's a typical case that's been called into our headquarters. A young woman presents with sudden onset of assaultiveness, lability, nudism, hallucinations, and nihilistic delusions. A neurologic exam reveals impaired recall, dyscalculia, and right-sided sensory deficits. Haloperidol is started by mouth and IM to treat her psychotic symptoms, but unfortunately, within a few hours, she develops a temperature of nearly 104 degrees Fahrenheit, tachycardia, diaphoresis, rigidity, tremors, and mutism, typical picture for NMS. On laboratory examination, her CPK is found to be 44,000, indicating rhabdomyolysis. She has an elevated white count, slowing on EEG. CT of the head is normal, but cerebrospinal fluid examination reveals 30 to 70 white cells with 98% lymphocytes. However, viral and serological screens are negative for a causative organism. So she appears to have some form of encephalitis that probably produced her initial psychotic picture and neurologic signs and symptoms. And this all became more malignant and neuroleptic malignant syndrome-like picture when haloperidol was started. She's administered steroids, diazepam, benztropine, and receives 3 ECT treatments, but remained rigid and unresponsive with temperatures rising to 105 degrees Fahrenheit, 40.5 degrees C. Then haloperidol was discontinued, and dantrolene and amantadine were administered, and over 2 weeks she became alert, verbal, and ambulatory. She had some mild memory deficits and dysarthria, but these resolved after 6 months with rehabilitation. So this is a typical case of NMS, which may be observed, complicating an underlying picture of encephalitis. And again, finally, it's important to be familiar with NMS and realize it is a drug-induced reaction associated with antipsychotics. So with that, again, if you have any questions about this, please feel free to contact us at the NMSIS website. And thank you very much for listening, and goodbye.